to begin by thanking the Danone Institute of Mexico for inviting me to talk about vitamin D and the immune system. In my presentation today, I'll focus on the mechanisms that link vitamin D to immune function, and I'll give particular attention to the possible impact of vitamin D on infectious diseases such as COVID-19. I have no conflict of interest to declare. My talk today is about vitamin D and the immune system, and I'd like to focus on the possible benefits of vitamin D for immune health. This is particularly important at the moment because immune health may be a key part of a successful response to an infectious disease pandemic. This is beautifully illustrated by the Swiss cheese model designed by virologist Inmune, who proposed that each response to the pandemic represents a layer of cheese, with personal responsibilities such as social distancing to the left and shared responsibilities such as vaccines to the right. Each layer or intervention is not perfect, but collectively they maximize protection of the individual. In recent years, it's been proposed that micronutrients may form another slice of intervention on the left by improving immune health. And in my talk today, I will focus specifically on one micronutrient, and that, of course, is vitamin D. The idea of immune health stems from the complexity of our immune system in responding to a challenge such as infection. This includes rapid, less specific responses such as barrier tissue integrity, activation of complement, and antiviral and antibacterial responses by phagocytic cells that are collectively termed innate immunity. There are also more specific responses primarily involving lymphocytes that sustain immunity, with this being referred to as adaptive or acquired immunity. Many factors influence the success of these two arms of the immune system, including micronutrients, which have been shown to enhance different components of the immune system. No single micronutrient is essential for any aspect of immunity, but some appear to have a much broader impact, and I'll focus on one of these today, and that is vitamin D. To begin with, we should perhaps remind ourselves of the key players in the vitamin D system. We get most of our vitamin D from the action of sunlight on our skin, although some foodstuffs, such as fatty fish, contain high levels of vitamin D, and in some countries, food is fortified with vitamin D. Whatever your initial source, vitamin D has to undergo two metabolic conversions to be functional. The first is in the liver to produce 25-hydroxyvitamin D, or 25D for short. This is the main circulating form of vitamin D, and it's this form of vitamin D that is usually measured in serum. If you're vitamin D deficient, you have low serum levels of 25D. However, this is an inactive form of vitamin D, and activation of vitamin D requires another metabolic step, mainly in the kidneys, to produce 1,25-dihydroxyvitamin D, or 1,25D for short, via the enzyme CYP27B1. Once released from the kidneys, 1,25D acts like a steroid hormone by binding to its nuclear vitamin D receptor, or VDR, in target tissues. It's this endocrine action of vitamin D that drives its most well-recognized effects in regulating calcium homeostasis and bone metabolism and protecting against the bone disease rickets. But there is another side to vitamin D. Some tissues, shown here as the lungs and the spleen representing the immune system, and the placenta, express vitamin D receptors, VDR, but they also express the vitamin D activating enzyme CYP27B1. So here, the tissues can take circulating 25-hydroxyvitamin D and convert this locally to 1,25D. This is known as an intracrine pathway, and it's this mechanism that is most closely associated with the extraskeletal effects of vitamin D that have attracted much attention in recent years. These are the antimicrobial, anti-inflammatory, and anti-cancer effects of vitamin D. Both the endocrine and paracrine actions of vitamin D are affected by vitamin D status. For example, vitamin D deficiency rickets is still a health challenge in parts of the world today. That includes the UK. However, it's been proposed that the intracrine pathway may be much more dependent on varying levels of serum 25D, so that if you're vitamin D deficient, the anti-cancer and immune effects of vitamin D may be less effective. And conversely, if you supplement with vitamin D, these effects of vitamin D may be improved. The best example of this is the effects of vitamin D on the immune system, where many cells express VDR, but some cells, such as cells within the innate immune system, also express the vitamin D activating enzyme CYP27B1. So this means that these cells, such as macrophages and dendritic cells, can make 125D and also respond to 125D. For example, when macrophages encounter a pathogen such as TB, they phagocytose the mycobacterium, but if left unchecked, the TB would proliferate in these cells and kill the macrophage. The cell therefore senses TB through pattern recognition receptors such as the toll-like receptor system or TLR system. This in turn triggers transcriptional responses, and two of the key genes that are induced in TLR responses to TB are VDR and CYP27B1. The intracrine 125D generated by this response can then bind to the vitamin D receptor and regulate gene expression itself. This includes increased expression of the antibacterial protein cathelicidin, or LL37 for short, that's incorporated into the phagosome to help kill the internalized mycobacteria. What this means is that if we supplement with vitamin D, we increase serum 25D, and this can then enhance 125D levels locally and promote bacterial killing. So this very simple intracrine model has been used to explain the benefits of vitamin D supplementation for immune health. And indeed, this model has been applied to many different aspects of vitamin D and human health. But clearly, it's not unlikely to be as simple as this. For a start, we know that these antibacterial vitamin D effects of vitamin D are specific to higher primates, which suggests that the ability of vitamin D to achieve these immune effects was part of human evolution. However, this also severely limits studies in vivo using mouse or rat models. We now also know that the innate immune actions of vitamin D involve more than one antibacterial response, and these now include effects on autophagy to improve the environment in which bacterial killing takes place, and also includes the regulation of intracellular iron concentrations to prevent bacteria from using iron as a food source. We also know that viruses can trigger similar intracrine vitamin D mechanisms to those seen with bacteria, with the potential to promote viral clearance. Many of these mechanisms, such as the induction of cathelicidin and DEFB4, are common to the antibacterial effects of vitamin D. So the take-home message from all of this is that vitamin D is a potent promoter of innate antibacterial and antiviral immunity. But what about the adaptive immune system? Of course, innate immune cells can also interact with lymphocytes to promote adaptive immune responses. As we've already seen, cells such as macrophages and dendritic cells can also generate 125D from 25D. This may act in an intracrine fashion to alter the ability of cells to present antigen to T cells, as shown here. However, there may be also paracrine effects, in that 125D produced by dendritic cells may escape these cells and then interact directly with T cells that are expressing the vitamin D receptor. Whatever the mode of action, intracrine or paracrine, the key effects of vitamin D are to suppress inflammatory Th1 and Th17 cells, whilst at the same time promoting tolerogenic regulatory T cells or Tregs. The overall effect of this is an anti-inflammatory response. In this way, vitamin D provides a double-edged sword for the immune system. So normally a double-edged sword would be one bad side and one good side, but here vitamin D promotes two good sides by suppressing bacterial and viral infection, whilst also limiting overexuberant inflammatory responses by T cells. It would be nice to think that this mechanistic link between vitamin D and immunity would have driven the exponential increase in public awareness of vitamin D and human health over the last few years. However, if we're being honest, we would have to say that our current view of vitamin D is primarily due to association studies that have linked vitamin D deficiency with a wide array of human health issues. Many of these are associated with immune function. This is infectious diseases, autoimmune diseases, and also many adverse events in pregnancy, for example, have been linked to immune function. This includes miscarriage and preeclampsia and so on. But in recent years, there has been much recent interest in the studies linking low levels of vitamin D and acute respiratory infections such as common cold, influenza, and of course, COVID-19. In the presentation today, I simply don't have time to discuss all of the publications that have linked vitamin D and COVID-19. However, mechanistically, there's a strong rationale for the link between vitamin D and COVID-19. This schematic of COVID-19 infection is very complex in that it shows the various stages of coronavirus infection from interaction with the ACE2 receptor through to the activation of complement, activation of innate immunity, as we've already discussed, through to the activation of adaptive immune responses, and then potentially detrimental effects on lung barrier integrity. They may eventually lead to acute respiratory distress syndrome, or ARDS, which can then have a major effect on mortality due to COVID-19. As we've already seen in the previous slides, the innate immune and adaptive immune effects of vitamin D can play a key role in immune responses to vitamin D in relation to COVID-19. However, beyond these immune responses, vitamin D may also improve COVID-19 disease outcomes by regulating ACE2 receptor expression and by enhancing lung barrier integrity, both of which are key factors in the development of acute respiratory distress syndrome. So it's possible that vitamin D may have some benefits even after COVID-19 disease has become established. In the last year, there have been over 500 PubMed entries on vitamin D and COVID-19, so it's difficult to summarize all of the activity on this topic. Data have broadly supported a link between low vitamin D status and increased risk of COVID-19 infection and mortality. However, studies have been heterogeneous, and there is still a possibility of reverse causality. More severe COVID-19 disease may cause more severe vitamin D deficiency. There have been some randomized control trials on hospitalized patients, but I think it's fair to say that these trials, these supplementation trials, have also been flawed. And this raises a key question about how we view vitamin D in relation to COVID-19. The core concept I presented to you is that vitamin D is a micronutrient that, like other micronutrients, can improve immune health and thereby help to prevent COVID-19 infection. But this idea has become somewhat confused in recent months with a small number of studies that have used vitamin D as a drug for treatment of patients admitted to hospital with COVID-19. The most prominent example of this is a study published in JAMA earlier this year, in which a mega bolus dose of vitamin D, or placebo, was given to a cohort of COVID-19 patients several days after hospitalization. This therapeutic use of vitamin D over a very short period of time, in this case about a week, had no effect on hospital outcomes. This was hardly surprising, as big bolus doses of vitamin D have repeatedly been shown to be effective. Here we're talking about 200,000 international units of vitamin D. Have been shown to be ineffective, mainly because they trigger potent feedback control effects that can negate any benefit of vitamin D supplementation. So the mantra here appears to be that little and often has the greatest impact in terms of vitamin D supplementation. So can we ever use vitamin D therapeutically for acute care patients? This is difficult because regular supplementation with vitamin D takes 1 to 2 months to achieve elevation of serum 25D status. One option that's currently being explored is to supplement with 25D itself instead of plain old vitamin D. The data shown here on the left are from a study carried out by my collaborators at UCLA, and compared the rise in serum 25D levels with healthy subjects receiving vitamin D, that's on the bottom dotted line here, with subjects receiving 25D itself. That's referred to here as calcifediol, its other name. As you can see, calcifediol produces a much more rapid rise in serum 25D levels and maintains these at a much higher level as well. There are several studies underway exploring the potential benefits of calcifediol for hospitalized COVID-19 patients. One of these, carried out in Cordoba, Spain, was recently published in Nutrients and showed a significant improvement in hospital mortality for patients receiving calcifediol compared to patients who received placebo. So where to next for vitamin D? More supplementation trials are needed, but these must be better designed and targeted at groups that need supplementation, namely people who are vitamin D deficient at the start. Many recent trials have involved populations that did not need supplementation at the beginning. However, a major barrier for any future trials is that we still do not know what the level of vitamin D is optimal for effects outside the skeleton. Similarly, all of the expensive trials that have been carried out with vitamin D supplementation to date have relied on measuring changes in one specific marker, 25-hydroxyvitamin D. But is this the correct approach? I'd like to end by proposing that in the last 10 years, we've oversimplified vitamin D by linking every aspect of vitamin D in human health to one vitamin D metabolite, 25D. This is partly because 25D is easy and cheap to measure, but there is so much more to vitamin D than simply serum 25D. For example, 25D circulates bound tightly to its vitamin D binding protein, or DBP, which, independent of vitamin D, has its own immunomodulatory properties. Indeed, our own work suggests that it is the unbound or free fraction of 25D that accesses immune cells. So should we be measuring free 25D instead of normal total 25D? At the moment, there is no validated assay for free 25D. Another consideration is that 25D is not an active form of vitamin D. Maybe we should be measuring 125D, the active form, instead. Although I've shown to you that intracrine and paracrine actions of vitamin D are important within the immune system, it's possible that some effects of vitamin D, for example, effects on neutrophils and natural killer cells, are driven by circulating 125D levels. Finally, in common with other steroid hormone systems, vitamin D has multiple metabolites that can act as reservoirs for vitamin D, or in some cases may have their own immunomodulatory actions. Recent work by my research fellow Carl Jenkinson has shown that circulating levels of the sulfated form of 25D are as abundant in the circulation as 25D itself. So does sulfated 25D play a part in vitamin D responses? Likewise, recent work by Robert Tuckey and Andrei Shleminsky has shown that CYP11A1, the CYP11A1 metabolite of vitamin D, 20-hydroxyvitamin D, is a potent anti-inflammatory hormone in its own right. These forms of vitamin D may be particularly important when we look at the effects of oral vitamin D supplementation versus natural vitamin D from UV light. And my final message would be that we have to go back to some of the fundamentals of vitamin D biology to understand the contradictory data that have been generated by supplementation studies in the last few years. I'd like to end by thanking my many collaborators and the funders of our research, and I'd like to thank you for your attention, and I'm very happy to take questions. Thank you.